Welcome to the 28th Annual Canadian Conference on HIV/AIDS Research. As we gather here today, we acknowledge we are on Treaty 6 territory and the homeland of the Métis. We pay our respect to the First Nations and Métis ancestors of this place and reaffirm our relationship with one another. We welcome you to these lands and look forward to learning and sharing with you over the next 3 days.
This year's theme is Winiska, a Cree and Saulteaux word that means wake up, awaken and rise. Winiska is a concept filled with optimism for the new day, which we greet with renewed energy and passion. Winiska is a verb, reflecting that as Indigenous people, our knowledge is action-oriented. This theme was gifted to us by the Saskatchewan Health Authority Patient Family Advisory Group on HIV. They gave it to us in the hopes that you will join us in collectively awakening and rising up to this HIV crisis here in Saskatchewan and elsewhere.
Indigenous peoples in Saskatchewan bear a shocking disproportionate health inequity for HIV. Even though 16% of the Saskatchewan population self-identify as Indigenous, they represent 79% of the persons newly diagnosed with HIV in the province. In addition, Saskatchewan has HIV diagnosis rates that are on average 2 to 3 times higher than the national average. Change is desperately needed, and the community is responding with innovative and effective solutions.
You will see this theme of Winiska infused throughout the conference, with the goals of helping us all to wake up and prevent HIV and better support people living with HIV.
At this time, we would like to recognize the members of the scientific committee who helped creating our scientific program while keeping this theme at the forefront. All members of the scientific committee in the audience with us today, please stand to be recognized.
Are those wild?
Thank you. Our program over the next few days features 7 special sessions created by the Scientific Committee, each with a focus on timely and relevant topics in the AIDS research arena today. Please ensure that you take advantage of all that CAHR programming has to offer and participate in these important sessions.
At this time, we would also like to recognize CAHR for the financial support given to the academics and members of the community in the form of scholarships to facilitate their participation in this important event. These scholarships are part of the overall effort of the CAHR Board of Directors to make the conference more inclusive. Over 125 full registration scholarships were offered to community members, along with 9 travel scholarships. In addition, 8 academic scholarships have been awarded. Now it is our great pleasure to introduce Elder Louise Half, who will open the conference for us. Please join us on the stage, Elder Louise. Louise Bernice Half, sky dancer, was raised on Saddle Lake Reserve and attended Blue Quills Residential School. She is married and has 2 adult children and 3 grandchildren. She graduated with a Bachelor of Social Work from the University of Regina. She also completed 2 years of Nietzsche training at St. Albert's Nietzsche Institute, where she also facilitated the program. Louise was awarded an honorary degree from Wilfrid Laurier University. She has served as Saskatchewan's Poet Laureate for 2 years. Her books, Bare Bones and Feathers, Blue Marrow, The Crooked Good, and The Burning in This Midnight Dream, have all received numerous accolades and awards. Engaging with an elder or knowledge holder involves protocol, and one must learn what is appropriate in each context. It is with humility and respect that we offer tobacco, a sacred medicine, along with an honorarium. Elder Louise, we would be grateful if you would open this 28th conference for us.
Good evening. Newatskisika moganimi töksilin sigasun unitsiskapu nehutsi kagiu pigian egohuta nuigen. My Cree name is Sky Dancer. I'm originally from Saddle Lake, Alberta, and as she mentioned, I am an author and a survivor of residential school. Usually, before I say prayer, I like to say a little bit about the subject that you are going to be witnessing and talking about, When I was in residential school, there was no such thing as sex education. And in fact, many of us were sexually abused in residential school, including myself. What's interesting is my parents were also residential school survivors, so I didn't learn about healthy sexuality. Now, in my training as in social work and my understanding of sexuality, when I talk to teenagers, I am very blunt with them. I don't beat around the bush, as I don't have time to. I'm getting older, and it's time to be straight. So I tell them where it's at, and they often tell me, "You're a lady, you're a woman." And I tell them I never profess to be a lady. But what I'd like to do is just invite you to think about what you're going into. I mean, we're talking about sexually transmitted diseases and needles, and it's really important to be out front in your education of the greater scheme of life, if so to speak. So what I would like to do, and I'm so honored to be here to share this prayer, is to thank the Creator for the life that we've been given, for this breath that we've been given, for each day is a blessing and it is a gift. And each morning when I bless myself with this smudge, that's what I say. I also ask, before I enter any stage, that the spirits, my guardian angels, will direct my speech so that I'm not making a fumble. So I'm going to say it in Cree, and I invite you in your own special way to join me in your own prayer and to praise the Creator for this new breath of life that you've been given and loaned, because life is a loan, and to thank that great mystery for this gift. Hai. Hana mamawik tawinan kia kata peitsagain amnu kumak ni masuma kiwa gawas ka mapik. Kinaskum na o asemim na kisagaw epewa pataman yawihin yeheon yumatsehun. Ewitsihin kwes kakwe mam tanetaman et maksi anais nista. Ugik kawitsihag kwistawal kapaskuna ki hammakamiase kakakwenstuhta ki huma. Tansise kawisi taso te kuiteaski. Kinaskum na o anamamawik tawinan. Umuta kap mutea kapaskuna ma hammakamiase kmeskano. Sagitun kawukupinama kakwe tapuitun mina kapikskwa. Kinaskum nen mamawik tawinan. I give you thanks. Hi. Thank you. Thank you.
Thank you so much. Community here in Saskatchewan and elsewhere are providing innovative solutions that work and are responsive to their specific strengths and needs. There are many AIDS service organizations, Indigenous communities, and federal and provincial agencies that we want to recognize. We will begin with presentations from 2 Saskatoon organizations with provincial mandates, and this will be followed by us recognizing many other organizations and communities doing great work. We will now call to the stage representatives from Sanctum Care Group, Caitlin Roberts, Jocelyn Martel, and Jan Martel.
Good evening, everyone. My name is Caitlin Roberts, and I'm the Executive Director of Sanctum Care Group, a non-for-profit that was formed in 2013. In 2015, we opened up Sanctum, which is Saskatchewan's first HIV hospice and transitional care home. Subsequently, we have opened up the Beehive, which is a transitional apartment building for people living with HIV, and HEART, our HIV/AIDS response team. Through an integrated wraparound approach to care, these programs have all demonstrated a statistically significant improvement in our patients' health and social outcomes. But for today, we would like to highlight Sanctum Survivor, an event that raises awareness and understanding in our community, and Sanctum 1.5, our newest initiative, which is Canada's first HIV hospice and Canada's first HIV and high-risk prenatal care home. To do that, it is my honor and privilege to introduce Dr. Jocelyn Martel, a previous Sanctum survivor, and someone who has been instrumental to the success of Sanctum 1.5.
Thank you, Caitlin. It's a very great honor to be invited to this meeting, and it's great to see so many familiar faces here. I practice obstetrics in this city. I've been here for 26 years in that profession, and I think I've seen a lot of women and a lot of babies. So I would like to give you a brief capsule of what I've seen as the impact of Sanctum 1.5 since it opened, and certainly the anticipation even before it opened. So I'm going to tell you about 4 different things that I believe has really been changed and impacted in the care that we provide and the outcomes that we have seen. And you are scientists, and I don't have great numbers. I have what I feel is the improvement, and they're all in the positive direction. We used to see these women very infrequently. They would not attend prenatal visits very often. It was difficult to capture them, even if you had an open door policy, which our practice always has. Even minimizing those kinds of barriers, these women didn't come. And now we see them come. They actually come for prenatal care. And I would say the impact of that has been 1.5. The second thing that I've seen is that we used to have to prompt these women to have conversations about all of the things that relate to prenatal care, labor, birth, the postpartum period. So talking about things like how to prepare for birth, how to prepare for breastfeeding if that's appropriate, how to prepare for a baby coming home, what to expect when you're in labor, where to go when you're in labor. And women often didn't initiate those conversations. We had to initiate them, and we felt sort of like we were lecturing them. And I would say that now, with the advent of Sanctum 1.5 and the cases and women and families that have gone through there, I would say the improvement and the impact of that has been at least 2.5. The third thing that I've seen is that these women almost never came for postpartum checks. And we know that postpartum checks are sometimes seen as mostly social, oh, isn't that a beautiful baby? But there's a lot of great work that gets done at the postpartum visit, including planning for the future, reviewing what the experience was. Of course, it's about the baby and about the mom and helping her make that transition into being a mother and adding that new person to their family. But these women never came. It's not like they only sometimes came, they never came. It was a sure thing that they would disappear. And I would say that the impact of Sanctum has been an improvement in that at least 5.5. But the biggest impact that I have seen, that has had the biggest impact on me personally, and everybody that knows Sanctum and knows me and 1.5 knows that I cry all the time, so I'll cry some more. There's videos of me crying endlessly. These women, when they came, never, ever, ever talked about the future. Never talked about it for themselves or for their babies. And now they do. They talk about their plans, what they see for themselves, what they see for their infants, and that to me is hope. And I would say that the impact of that has been 10.5. Thank you. Okay, this is my cousin, Jan Martel. He was a survivor. He's going to tell you his experience.
If you didn't hear her, that was my cousin introducing me. I became involved with Sanctum Care Group when a friend reached out and asked me if I would consider doing the Sanctum Survivor Challenge. That's how it started. That was the essential first step, someone reaching out. I hesitated. I have a busy, fulfilling life, a novel on the go, a lovely family with 4 young children. Why give that up? Why bother? Maybe I could just make a donation, give money instead of time. I finally said yes, because the challenge seemed intriguing. What is it like to be homeless? I showed up one morning at 6 a.m., traded my normal clothes for a random selection of donated, ill-fitting clothes, and there I was, dressed for the part and asked to play the part, asked to be homeless. That meant no emails to read, no calls to make, no errands to run, no novel to write. For 36 hours, I faced the challenges that homeless people face every day. I had to find food. I had to exchange needles to get clean ones. I had to get tested for HIV. I had to find a methadone clinic. I had to find a toothbrush and toothpaste. I had to wash the clothes on my back in a laundromat. I had to find a place to sleep the night. I slept in a playground on pieces of cardboard wrapped in a too thin blanket. I froze. Of course, this was all pretend. I'm an overprivileged, empowered white male. I've had so many doors flung open for me my whole life that it would take more than 36 hours of closed doors to make me feel homeless on the inside. I was on top of a reef, just peeking into the depths where the sharks swim. There are people whose life this is every day. Many are vulnerable women. Many are teenagers, barely out of childhood. Many have major health issues. Many of them have never been properly loved, even as babies. They live in their inner being with wreckage. And many, every day, are ignored and mistreated by the systems in place. Their suffering stills the heart, and it takes place just over there, a few blocks away. Now I support Sanctum Care Group and other social justice initiatives the best I can. I encourage you to do the same, each of you in your own way, wherever you live. We'll only make it if we all make it. Thank you. Have a good conference.
Thank you, Sanctum Care Group, for wonderful presentations. For our next organization, we welcome to the stage Jason McCurdy from AIDS Saskatoon.
Hello, welcome to Treaty 6 territory in the homeland of the Métis. My name is Jason McCurdy. I'm the Executive Director at AIDS Saskatoon. So I'm just going to tell you a little bit about ourselves. So we were established in 1986. We provide outreach, education, drop-in, and advocacy services. We serve both people living with and those considered at risk of HIV, AIDS, and hepatitis C. One thing, disclosure is not required to access services with us. So what does that mean? It means we're quite busy. So we have 2 outreach programs. Our family support program, we operate 365 days a year. Last fiscal year, we supported 390 families. We transported 2,288 times. So that's everything from a medical emergency, escaping domestic violence, to something as simple as going to get food at the food bank. We do a lot of crisis intervention. Our staff are very dedicated and motivated. And we do a lot of prevention of children being apprehended, and we have a very good working relationship with the Ministry of Social Services. We also have a support services program to support people that maybe don't have kids with them. Maybe they're single, maybe they don't have kids anymore, they left the house, or maybe they were apprehended. So that program is also quite busy, and they do a Herculean effort. There's 812 people that we supported last year, and that's with an outreach team of 3 people. We did 6,393 instances of support. These aren't easy solutions either. One of the things we did is we led an inquiry with the Ministry of Justice on a child who died while they're in custody from an overdose on crystal meth. So these are very complex cases that we work with. These aren't just a simple hand out a pamphlet and move on to the next thing. We did 2,971 referrals. We rely on our community partners, Sanctum Care Group, Westside Community Clinic, Saskatoon Travel Council, Out Saskatoon, Saskatoon Sexual Health, and so we really do value those partnerships. We did 752 transportations to appointments, and we housed 57 people. That's with 1 housing worker. We housed, out of all the housing programs in the city, we have the least amount of staff, and we house the most people. So that shows you how good we are at those navigating of services and engaging people that are very hard to engage. We do a lot of support systems, navigation, advocacy, and referrals, and Julia, who runs this department on her spare time, also wrote a manual so that people who access services can better understand how to access income support, and we really worked hard with the ministry to develop that manual. We do a lot of education and awareness. So we've developed an HIV and hepatitis C through the Medicine Wheel course that we've done throughout all of Saskatchewan, including on and off reserve. We designed the Saskatchewan HIV awareness flag. It's something that's been in place now for 2 years, so every AIDS Awareness Week, towns, cities, reserves, and at the legislature, they raise that flag to help raise awareness on HIV-related issues. We co-founded National Testing Day. That initiative started in little old Saskatoon with like 10 of us meeting in an office trying to figure out how we could pool our pennies together. And since then, it's ballooned in 2.5 years into a national movement. We're very proud of that. Canadian AIDS Society is taking the lead now. We do harm reduction training, workshops, YouTube. We have a YouTube page where we train people, both service providers and service users, on how to use safer smoking equipment, and we're developing more videos as we speak. And we do mentorship for many outreach programs, especially in rural areas that don't necessarily have the support for their staff. We try to support where we can. We've done a lot of resource development, so we've done HIV and hepatitis C materials that are available in Woodlands Cree, Plains Cree, Dene, and Michif. We're doing SODO, and we don't have Michif yet. We're doing SODO and Michif, which is the Métis language, this year. We've done the first ever Aboriginal language condom campaign that has condoms in Michif, Dene, and Cree in English, and we were able to do that with Saskatoon Sexual Health, one of our main partners. We do posters and wallet cards promoting safer pipe use in the city, and we've done specialty lip chops that are available. All of our resources are available at the share table if you're interested in looking at them. So here's the provincial awareness flag. We have these on stickers. We have flags. We're developing T-shirts. We really want to get this out there as an anti-stigma message, and it's a nice message for Saskatchewan. It's a true Saskatchewan message. The tiger lily wrapped like a nice warm hug in the HIV ribbon on the Saskatchewan flag. Here's one of our posters, so do your veins need a break? So we're promoting pipes because, I'll get to that in a second. Here's our condoms, so we have condoms available. They're Indigenous jokes, so I apologize if you don't get them. But I can tell you they're a hit in northern communities. We've distributed 200,000 condoms in a year and a half through 49 northern communities. These are communities that before this, a lot of them did not have access to sexual health, safer sex materials. This is something we're very proud of, and we did this all through fundraising. So one of the things that we are getting a little bit more known for is our advocacy efforts. You've probably seen us in the media shooting our mouth off about something. So in the last year and a half, we were able to successfully advocate for the deregulation of naloxone in the province. Now nonprofits have the right to distribute naloxone. Before, it was very limited access, and we weren't able to do that alone. We had good allies in the Ministry of Health. We had a good ally with the Minister of Health and with the Saskatchewan Health Authority. We successfully advocated for the implementation of meth and crack pipes across all of Saskatchewan needle exchanges. And then one of the biggest things we did, which is we did under the radar, is we wrote the latest policy for the Ministry of Social Services. So as of this July, people on the disability program, which includes many people working on peer programs, are now going to be able to earn $500 a month, which is up from $200 a month, and they're going to be able to annualize it. So peers that suffer from seasonal depression and can work in the summertime are going to be able to earn $6,000 if they want in a month, and then they won't have any clawbacks. Before, if they made over $200 a month, they'd immediately set clawbacks and they could lose their benefits. It's the first wage increase and earnings exemption on income assistance in 20 years. We wrote that policy. We did a lot of research on that policy. And we're looking to do more. As you probably know, we're looking to establish the first safe consumption site in the province. This is a big effort. We've been going to door to door. We've been meeting with politicians pretty much every evening and weekend. We're meeting with people in the community to talk about this, to make sure that their understanding is up there. And just a little quick shout out, there's our little baby there. She'll be up and running soon. And we're really excited to be located next door to Saskatoon Tribal Council Health Center and the Westside Clinic, and start really working together in a good way. Not that we don't already, but it'll just be nice when we can actually talk to each other without just running into each other in passing. So yeah, thank you for your time.
Thank you, Jason. Thank you for a wonderful presentation. And there are many more community organizations we want to recognize. And it makes me so proud. I grew up in Saskatchewan. I think I'm going to cry just from those two presentations. We are small, but we are mighty. Okay. There may be too many organizations and communities doing great work to rightfully give credit to during this opening session, but we will try. And this is a very different landscape in Saskatchewan compared to 9 years ago when CAHR was first here. This is why we really want to emphasize how much community has been doing in this time. These organizations will be listed here on the screens, and I hope that you will look some of them up if you live nearby to actually volunteer or maybe consider donating. But first, I would like to start with telling you all that when I was communicating with all the people in Saskatchewan doing the good work, many of us wanted to recognize Dr. Kurt Williams, and those of you in HIV research for many years will of course know who he is. He was one of the co-chairs of CAHR in 2010, the last time it was in Saskatoon, and he is credited with starting many of the HIV/AIDS-related initiatives in Saskatchewan. He has worked tirelessly to see these programs develop and come to fruition, including the Westside Clinic, where Dr. Williams and others, including Dr. Skinner, that's part of our organizing committee, and Dr. Hellier, were instrumental in recognizing the start of the HIV crisis in Saskatoon. We also heard from many people that they did not want to take credit for anything alone, since they work with so many partner organizations, and that this is the key to their success, their partnerships, that we may be a small province, but partnerships enable us to do the work that needs to be done. Out Saskatoon emphasized their many partnerships, for example, with AIDS Saskatoon and the Sexual Health Authority Sexual Health Clinic. The partnership with the Sexual Health Clinic has allowed them to start many programs, such as a PrEP clinic that began at the community level. We also heard the importance of partnerships from the Saskatchewan Prevention Institute that has supported AIDS service organizations to reduce mother-to-child transmission. And again, from the population and public health through street health, sexual health, and positive living program teams who are working with partnership with Community HIV Steering Committee that have built the depth in programming that we witness in Saskatoon today. And we also heard from the Persons Living with AIDS Network of Saskatchewan, the PLWA, a community-based Indigenous organization promoting wellness for people affected by HIV/AIDS. The PLWA was founded in 1986 by 4 HIV-positive peers. Their mandate continues, and is to create a positive attitude and engender a feeling of hope for persons living with HIV and AIDS, including their friends, families, partners, and to provide a space where they may come together. The PLWA operates a drop-in and wellness center with many programs and is well known among its members as a culturally safe place where they are all treated with dignity and respect. Saskatoon also has CAHR, the Saskatchewan HIV/AIDS research endeavor that works closely with clinicians, communities, and people with lived experience. A major goal of CAHR is to demystify the research process by helping people turn ideas into potential studies. In Regina, there is All Nations Hope Network that works to provide for the physical, spiritual, and social needs of Indigenous people living with and affected by HIV and hepatitis C, and to empower them to be meaningfully involved in decision-making processes that affect their lives. Their mission is to provide culturally safe HIV and hepatitis C prevention, education, training, awareness, and support. They offer workshops and have a drop-in center where people can have access to ceremonies and elders and many other support services for people's daily lives. Even more, All Nations Hope is doing research and recently secured their own large grant. Also in Regina, there is the Regina General Hospital Infectious Diseases Clinic that runs the HIV Collaborative that is within the Ministry of Health. They're running the first non-physician PrEP clinic in Regina with the support of nurses and pharmacists. In 2018, the AIDS Program South Saskatchewan, located in Regina, distributed over 1.5 million needles, over 25,000 condoms, tested over 200 people, and in 2019, they started distributing crack and meth pipes to lower HIV and HCV transmission rates. Their services also include a client care coordinator that works with individuals to determine personal needs and together design supportive plans. In Kamsack, there's a New Beginning Outreach Center that is part of the Cote First Nation that has drop-in services, daily lunch programs, and a women's group. In Yorkton, the Sign Outreach Social Program has a very dedicated staff, Candace, that travels around Yorkton to support people living with HIV in any way that they might want to address their own barriers that they face, such as simple things like getting ID, bank accounts, or even maybe just finding donated maternity clothes. In Prince Albert, the PA Métis Women's Association HIV program team has been doing research on different social indicators and risk factors related to the HIV epidemic. There is also a field educator that delivers educational presentations to high-risk populations, a harm reduction worker that has a frontline contact, and all of this is funded by the Public Health Agency of Canada. Also in Prince Albert, the Access Place Sexual Health Clinic provides confidential sexual health services such as rapid HIV testing, treatment, HCV and HIV care programs, educational presentations, and distribution of naloxone kits, as well as condoms and other services. And even further north, there is also the Lac La Ronge Indian Band Health Services. That is a First Nation transferred health organization providing health services to community members of the Lac La Ronge Indian Band in La Ronge, Sucker River, Grandmother's Bay, Hall Lake, and Little Red River. This organization is one of 4 partners comprising the Northern Intertribal Health Authority, and they've been increasing capacity and testing in their communities with point-of-care testing and dried blood spot testing offered at all community events. They offer comprehensive harm reduction and needle exchange programs at all clinics and offer community awareness and education workshops annually, especially for youth. And this leads to my last but certainly not least acknowledgement of the Know Your Status program that recently had a forum that was organized by the Katikoop Cree Nation, Saskatoon Tribal Council, including 7 communities, and Big River First Nation. This program has led to over 40 communities with HIV testing available, and a First Nations and Inuit Health Branch team of nurses to educate, test, and follow up. These are just some highlights of what our communities and community organizations are doing in the fight against HIV. I think we do not hear enough about these successes in the news about HIV in Saskatchewan. At this CAHR conference, we want to celebrate our community and enable them to communicate their research successes, their outstanding issues, and provide the opportunity to problem solve with others around Canada. I would like to ask now that Dr. Kurt Williams and the people from the many organizations I mentioned and that came up on the screens to please stand so that we can acknowledge and thank you with a round of applause. At this time, we would now like to turn the stage over to the CAHR President, Dr. Curtis Cooper.
I'm grabbing my water.
So good evening, and thank you to Alexandra and Linda. And I'd like to thank the entire CAHR 2019 organizing committee. Just fantastic job so far. As president, it's a great honor to take part in the official opening of the 28th CAHR conference. I'd like to take this opportunity to recognize the members of the CAHR Board of Directors for their hard work and volunteer commitment over the last year. This is a fantastic, dynamic, diverse, fully committed group that have done fantastic work on behalf of CAHR. So thank you very much. Of course, I'd like to thank the sponsors. Without their ongoing generous contributions year in and year out, CAHR would not be able to host this great conference. And I encourage you to visit them in the exhibit hall over the course of the next several days. The annual CAHR conference is the premier gathering in Canada for those working in all disciplines of HIV research, as well as policymakers, persons living with HIV, and all individuals committed to ending the pandemic. As someone who was born and raised in Regina and attended the University of Regina and University of Saskatchewan, I'm thrilled to be back here in Canada's greatest province. And after hearing some of the fantastic work that's happening here, I've never been prouder to call myself a person from Saskatchewan. Saskatchewan, as you know, is home of the 4-time Grey Cup winning Saskatchewan Roughriders, which may seem impressive until you realize that they've been in existence for 109 years. But of course, we're not here because of idle pursuits like football. We're here because of very serious things that are going on in the province. And so I'm proud to say that the CAHR board has made the strategic decision to return here again in this year. Our decision to return to Saskatoon rests on the fact that Saskatchewan has the highest rate of HIV in Canada, and Indigenous populations within Saskatchewan and throughout Canada continue to be disproportionately affected. Hosting the conference in Saskatchewan once again provides a platform to illustrate this reality, and allows our amazing local scientific committee to showcase how far they've come since 2010 when we were here last. Overall, CAHR 2019 will be a tremendous opportunity for all researchers and community members from across the country to share the latest scientific advances in the field, learn from each other's expertise, and develop new ways to treat and prevent HIV. I hope you enjoy the conference, and thank you in advance for your contributions, participation, and support. I would now like to invite Mr. Alex Filhatro, CEO of CAHR, to join me on stage to introduce this year's winners of the CAHR Excellence in Research Awards. These awards highlight and celebrate the contributions of Canadian investigators in HIV/AIDS research in Canada and internationally. Each year, up to 5 awards are bestowed to mid-career researchers across all tracks. The recipients of this award have proven track records of excellence and have demonstrated a commitment to improving the lives of those living with or at risk of contracting HIV. As I read their names, I will ask that the awardees come forward and receive the prizes. The winners of the 2019 CAHR Excellence in Research Awards are, in Basic Science, Blake Ball. In Clinical Sciences, Kelly O'Brien. In Epidemiology, Public Health, Sharmistra Mistra. And in Social Sciences, Trevor Hart. And the Community-Based Research Award is being awarded to 32 women living with HIV who are the peer research associates of the CHIWO study. So they are the brains, hearts, and soul of CHIWOS and have dedicated their expertise, brilliance, and passion to leading community-based research by, with, and for women living with HIV. The CHIWOS PRAs here today are Kerrigan Beaver, Claudette Cardinal, Valerie Nicholson, Jasmine Cotnam, and Stephanie Smith.
I was told I wasn't allowed to talk, and that woke up the mama bear in me. I am taking 1 minute of your time to honor the 32 peers living with HIV that gave their time and voices to research, and to honor Marisol, one of our PRAs that has gone on before us, and to honor all our allies that really do get it. And together, we are the future of research.
Great. So we're going to have some photo ops, and then we will move on.
back for them? I'm so sure. Is he giving away phones? It is now our privilege to bestow the CAHR2019 Red Ribbon Award. This year's awardee is Trevor Stratton. Trevor is an inspirational citizen of the Mississaugas of the Credit First Nation near Toronto. He is of Ojibwe and English heritage. He is two-spirited. Diagnosed with HIV in 1990, Trevor turned to his community and the Indigenous HIV/AIDS movement for support. Over the years, Trevor has become a leading activist, volunteer, and consultant. He serves in many capacities, providing leadership nationally and internationally. Although he does not consider himself a researcher, Trevor has been involved with and transforming community-based HIV research. He has also contributed to the emerging discipline of Indigenous research. Both philosophical underpinnings as well as methodologies. Please welcome to the stage Trevor Stratton.
Just don't forget it.
Some of you may recognize the background in that picture. That's the wallpaper in Air New Zealand in their planes. It's not my library. I really want to thank CAHR for, year after year for acknowledging the contributions of people living with HIV and the recognition of the greater involvement of people living with HIV and AIDS. It's meaningful. In accepting this award, I have to acknowledge and accept the award on behalf of the research culture that's been built over the last 10 to 15 years in the Indigenous community, and my main employer, the Canadian Aboriginal AIDS Network, and their large role in that. There's so many others who I could see standing up here and me applauding for them. They're my mentors, and I've been a mentor to others. And I'm saying this because we all play this small part in the research culture. We all find our roles and responsibilities to contribute. In my case, more of a cheerleader and community convener and bringing the international into our work. And I'd like to thank those organizations, including the Canadian Aboriginal AIDS Network, who make space for people living with HIV and the key affected populations without building a road for us, but allow us to build our own road. Bring us together and let us come up with our own research questions and our own ideas, our own methodologies, and then come forward with a unified voice into forums like this. And there are organizations that do that, and I applaud that. It just seems like the right thing to do. It seems ethical. And that brings me to something I'm proud of that the CAN did, and as well the International Indigenous Working Group on HIV and AIDS. We came up with what we thought would be an ethical protocol for engaging Indigenous peoples in HIV, but it turned out to be what we call Conducting Research on HIV Among Indigenous Peoples, Values, Approaches, and Guidelines. And it refers to the free, prior, and informed consent. It refers to the collective rights of Indigenous peoples enshrined in the United Nations Declaration on the Rights of Indigenous Peoples. And if you're going to be working with Indigenous peoples, of course there are ethics boards, but there are also Indigenous ethics, which I might argue would be even more stringent. And this two-eyed seeing is the way Indigenous peoples do our work, and I hope this becomes the gold standard. And I'm very humbled to be around so many people who give a shit. Thank you.
Thank you, Trevor. We look forward to seeing you and speaking with you over the next few days. We are now honored to introduce our Dr. Mark Wainberg Lecturer for 2019. Dr. Mark Tyndall is a professor at the University of British Columbia. His doctoral degree in epidemiology from Harvard University focused on health and human rights. He has conducted research internationally in a number of countries, particularly in Kenya. In Canada, he has provided leadership in Ottawa, Vancouver, and British Columbia more broadly. His career awards are many. He is an author on over 250 peer-reviewed publications and has won awards for his teaching and mentorship. In 2017, he presented a TED Talk on harm reduction that has generated over 1.2 million views. Dr. Tyndall has conducted numerous community-based research projects, including epidemiological studies on HIV and hepatitis C, ART access among people who inject drugs, healthcare utilization among marginalized populations, and harm reduction. Most recently, his focus has been on the devastating overdose epidemic in Canada, where criminalization of people who use drugs, poverty, trauma, and the failed policies of drug prohibition have set the stage for a public health crisis. Please welcome Dr. Mark Tyndall to the stage.
Thank you. Do you have to get a picture? Okay, picture. Okay, great. Thank you very much for the introduction. As we've been sitting here for about an hour, I would suggest that everybody take one moment and just stand up and stretch your legs. I'm a public health doctor. I'm trying to keep people as healthy as possible. Okay, that's enough. Sit down, please. Firstly, I would like to acknowledge that I am a white settler on stolen land. I am aware that this acknowledgement is meaningless unless I am committed to actively walking the path of truth and reconciliation, and I'm doing my best to do that. It is a real honor to present the 2019 Mark Wainberg Lecture. I have attended many Mark Wainberg lectures, and some of my closest colleagues and mentors have had this responsibility. The big difference this year is that Mark is no longer sitting in the front row. It is also the first time that Mark hasn't been able to make some self-deprecating remarks about his own mortality and how someday this will be a memorial lecture. I had the opportunity to get to know Mark and count him as a friend. If given the chance, I'm sure he would have made some mention of how he destroyed me in a debate around treatment as prevention at the CAHR conference in Montreal in 2008. That wouldn't be true. We will all miss Mark's intelligence, enthusiasm, and passion, and recognize that the Canadian and global HIV family have suffered a tremendous loss with his passing. I hope that my remarks today would be in keeping with what Mark would have championed himself, and I know that I have been influenced in my own advocacy work by his unwavering commitment to social justice and speaking out for those without a voice. I've had a while to consider what I wanted to say today, as I know this is a once-in-a-lifetime opportunity. What became clear to me as I considered this is how long I've actually been doing this work in HIV. My career, and in some ways my life, has been driven by this one disease. I started medical school in 1982, which was about the same time that the first cases of AIDS were being described. And while I have seen incredible scientific advances in diagnostics, treatment, and prevention over these years, changing the social and structural forces that propel the epidemic has been less incredible. On some issues, we have made little or no progress. Year after year at the CAHR conference, we hear about many of the same challenges, the same risk factors, the same vulnerable populations, and too often the same outcomes. I think it is time to do things differently, to learn from people like Mark Wainberg, to change some rules, to speak out about things that have strangled some of our best prevention efforts, to spend more time rolling out interventions and innovations and less time trying to come up with the perfect research question, to honor the people who have truly suffered from this epidemic by directly involving them in solutions, ultimately to become stronger advocates and be willing to break some glass. For this year's lecture, I tried to come up with a provocative title, Does HIV Cause AIDS? Now, for those of you who know Mark Wainberg, a title like that would have caused him to go apoplectic. Mark is internationally known for his stand in South Africa, where he went on an absolute tear to eviscerate then President Mbeki and a group of HIV deniers who were challenging the connection between HIV immunodeficiency and the effectiveness of antiretroviral treatment. Wherever you are, Mark, my intention is not to question the biology of HIV or the effectiveness of antiretroviral treatment. I am 100% convinced that HIV is the pathogen that directly causes immunodeficiency and that the drugs designed to stop viral replication work amazingly well. However, with the tremendous improvements in our treatment and the availability of treatment globally, no one actually has to get AIDS. No one has to die because their CD4 cells have been wiped out by a virus. Yet, this is still happening. Further, no one actually has to get HIV. With what we know about transmission and the available prevention tools that we have, there is no reason that viral transmission has to occur. Yet, this is still happening. It is now widely acknowledged that HIV is a disease of inequality, discrimination, and neglect. This acknowledgement has spawned a whole range of responses focusing on what are commonly called high-risk groups or vulnerable populations or key affected populations. In fact, many of us have chosen areas of interest and research that focus on a particular group of people. And while we have danced around with the least offensive terminology, we can never escape the fact that when we associate HIV infection with a particular group of people based on race, ethnicity, sexual orientation, occupation, or a chosen behavior, we risk alienating, victimizing, and stigmatizing the entire group. Remember the 4 H's that were widely used to describe the epidemic in the early 1980s. Homosexuals, hemophiliacs, Haitians, and heroin users. What terrible damage that did through blame, fear, and discrimination. In some ways, we have never recovered. The heroic struggles to push back on a system that is best slow to respond and at worst discriminatory and negligent is what I would like to talk about today. I think there are some valuable lessons to be learned if we look where things have moved forward and where things have stalled or even regressed, where we have been able to change the laws and structures that impede our work and where we haven't, and where we have seen people step forward as champions and where nobody has. Mostly, I hope to challenge us all to be meaningfully engaged as change makers. We need to commit to creating real change. It is simply not acceptable to document the challenges without pushing back. I would like to go through some of the hard-fought victories that have happened in HIV and the central role of advocacy and activism. It should be stated up front that some of the strongest voices in these movements have come from Canada. These include policymakers, medical leaders, and researchers, but most of the credit goes to members of the communities themselves who have risked everything to create change. As you will see, all these struggles have one thing in common. Change came through people who were unwilling to back down despite the barriers. In fact, the actual evidence to support these ideas often came later. The interventions were based on doing the right thing versus acting on available scientific evidence. Let's start with the pivotal work of Mark Wainberg, who led a response to HIV in Africa. At the time, the world was faced with a rather stark question. Should people in Africa who are unable to access antiretroviral therapy simply be allowed to die? This is quite a profound question. And there was a time when most people, at least by their silence, said yes. Basically, it was argued that it was too complicated and expensive to treat poor people in faraway places. And the multinational pharmaceutical companies who controlled the drugs saw little opportunity for profit and held on tightly to their patents. Oh, slip that one in so you get your CMA credits. In the midst of this debate around whether or not to provide antiretroviral drugs to Africa, there emerged a rather bizarre twist: claims that HIV did not cause AIDS. This was the last straw for Mark Wainberg, who led a charge to call this out. This is classic Mark Wainberg look of exasperation. You can fill in the caption. You could start with, "What the?" And I hesitated, but I won't continue with that line, but you can fill in your own caption. The tribute to Mark Wainberg that occurred in The Lancet really described this quite well. Mark planned the 2000 Durban HIV conference specifically because the South African president was refusing to accept that AIDS was caused by HIV, says David Edelman, Vice Principal for Health Affairs and Dean of the Faculty of Medicine at McGill. This speaking truth to power was very much part of his personality. He was not afraid to open his mouth and say what had to be said, and with enormous effectiveness. This type of leadership opened the door to community-led organizations and gave credibility to a groundswell of protests and activism to demand treatment globally. One of the most important lessons from this rollout of antiretrovirals in Africa was that it was not evidence-based at all. No one really knew if you could successfully supply drugs to poor urban and rural areas in Africa. No one knew you could treat HIV without doctors. No one knew if people would take the drugs consistently. No one knew whether the supply chain could be maintained. No one knew where sustainable funding would come from. And no one could be sure that massive drug resistance wouldn't develop. The provision of life-saving medications was just the right thing to do, and any unintended consequences would be dealt with down the road. The move to antiretroviral treatment scale-up could not be stopped just because of all the unknowns. The rest is history, although the fight to supply people with antiretroviral drugs is far from over. In January 1990, years before effective HIV treatment was available anywhere, I moved to Nairobi, Kenya to work on the University of Manitoba project as part of my infectious diseases fellowship. It is interesting to note that Frank Plummer, Stephen Moses, Ken Rosenthal, and Bill Cameron also worked in Nairobi and have presented the Mark Wainberg Lecture. Working in East Africa during the 1980s and 1990s was life-changing for us all. HIV was spreading like crazy, and there was basically nothing to stop it. The mighty condom was basically the only thing separating people from infection, and it was proving to be entirely inadequate. During the 1990s, literally millions of people in East and Southern Africa were acquiring HIV. Most had no idea they were being infected, and there was generally very little attention paid to the epidemic. Obviously, the impacts on families and communities was devastating, but most people suffered in silence. The governments at the time hardly mentioned HIV, while people were dying all over the place. This is a picture taken outside the Special Treatment Clinic on River Road in Nairobi in 1990. That was my Project CAHR. I was living the expat life. The lineup for the clinic generally started around dawn, and between 500 and 800 people filed through the clinic every day. That isn't counting the hundreds of people who were routinely turned away. People were referred to this particular clinic from all over the country if they had any complaint between their waist and their thighs. My research project focused on genital ulcer disease. At that time, men presenting to this clinic with a genital ulcer had a 50% chance of being HIV positive. They would all later die of AIDS. We are still living with the dark ages of rampant HIV transmission in the region, as a massive disproportionate burden of HIV exists in Southern and Eastern Africa. And despite the notable achievements of bringing HIV medications to Africa, it took far too long. In North America, the number of deaths due to AIDS peaked in 1995, which is the same year that clinical trials for HIV treatment showed excellent results. In Africa, meanwhile, AIDS-related deaths only began to decline in 2007. That is over a decade later. Millions of people in Africa died without access to treatment when effective treatment existed. While the scale-up of antiretroviral drugs in Africa will be remembered as a great global achievement, at the same time, history will show that the delay in scale-up was one of the biggest failures. Only after years of protest and advocacy was antiretroviral therapy scaled up. A critical turning point came from the PEPFAR initiative, led by President George Bush, who committed $15 billion between 2004 and 2008 to provide HIV treatment and care. The Global Fund has continued to support the cost of antiretroviral treatment, and without these programs, it is hard to know what the global HIV epidemic would look like. But there is still a long way to go. While aspirational targets like 90-90-90 and the end of AIDS by 2030 are necessary and important international goals, in 2017 it was estimated that only 60% of people living with HIV were on antiretroviral treatment. This large treatment deficit is driven mainly by coverage in low-income countries, especially Africa. Despite this unfinished business, in Canada, we rarely talk about our obligations to support the global campaign on AIDS. In North America, AIDS emerged as a disease affecting gay men. The evolution of gay rights during my lifetime has been quite extraordinary and has been closely intertwined with activism around AIDS. In the history of public health, there has probably never been a stronger call to action than shown through the advocacy and sacrifice of men living with HIV in the 1980s. ACT UP really defines what activism can do, and the silence equals death graphic is profound in its simplicity. One of the best records of the early days of the HIV activism can be found in Randy Schultz's 1987 book, And the Band Played On, that chronicles the activism in San Francisco. A quote from the book is, "Most importantly, the epidemic was only news when it was not killing homosexuals. In this sense, AIDS remained a fundamentally gay disease, newsworthy only by virtue of the fact that it sometimes hit people who weren't gay. This book had a profound impact on how I viewed HIV and how activism was critical for change. Society did not act, largely because they really didn't care about gay men dying. The movie How to Survive a Plague also had a profound impact on my understanding of activism, as it chronicled the impact of a social movement. The whole trajectory of HIV was changed by the relentless activism of ACT UP. David France, the director of the movie, later published a book by the same title in 2016. I'd like to read a brief excerpt from that book. I had arrived in New York City for the first time for a college internship at the United Nations and a chance to explore Christopher Street, the mountaintop of gay life. I was not yet comfortable there, but Manhattan struck me as a city of promise, at once grimy and magical, where people could hide and be found. My college roommate Brian, an artist, and I took up in a tiny one-room apartment in Midtown, sleeping chastely on opposite sides of a narrow, lumpy bed. Our timing was unfortunate. Just 2 weeks after unpacking, on the Friday, the 4th of July weekend, the New York Times carried the first news of the plague. Quote, "Rare cancer seen in 41 homosexuals," ran the headline. The cases were concentrated in Manhattan, with a few in the San Francisco Bay Area as well, and consisted of violet-colored spots appearing somewhere on the body, easily mistaken for bruises, though they were sometimes raised and textured. 1 in 5 of the affected were already dead. The article noted that, quote, "Most cases had involved homosexual men who had multiple and frequent sexual encounters with different partners, as many as 10 sexual encounters each night, up to 4 times a week. Many of the patients have also been treated for viral infections such as herpes, cytomegalovirus, and hepatitis B, as well as parasitic infections such as amoebiasis and giardiasis. Many patients also reported that they had used drugs such as amyl nitrate and LSD to heighten sexual pleasure." That's from David France. To me, looking back, it is quite incredible to read this piece in the New York Times. What stigmatizing and sensational reporting. The article described the people dying from this mystery disease as less than human, aberrant sexual behaviors, vectors of all kinds of unpronounceable infections, and pleasure-seeking drug use. This was on top of the extreme prejudice that already existed toward gay men. The underlying message was that they were deserving of this. It is a narrative that has been very difficult to reverse and is unfortunately still around. People who get HIV are somehow deserving. Victim blaming still happens in our conversations, in the media, and by our political leaders. It almost always goes unchallenged. I had the opportunity to attend the International AIDS Conference in San Francisco in 1990. I was able to watch the activism firsthand, marches in the street, tearing down pharma booths, screaming at politicians. It was the best AIDS conference ever. I actually attended this conference with an entourage of colleagues from Kenya. Watching the dykes on bikes riding motorcycles during a conference demonstration was an unforgettable experience. It was all new to me, but my Kenyan friends, many of whom had never traveled outside the country, basically had their minds blown. It is clear that without the ACT UP movement, effective treatment would have been delayed by years, maybe many years. Again, the treatment availability was not based on a lot of existing evidence. People were dying and demanding to receive treatment. They were willing to take chances. They didn't have time for the FDA approval machinery to give them the go-ahead. They weren't going to wait for randomized clinical trials to be published in medical journals. They could not wait to see if these drugs had long-term side effects. Under such dire circumstances, people were demanding action, and ACT UP was the driver of this action. As we've heard, front and center at this conference is the inadequate response to HIV among Indigenous peoples. This is especially stark right here in Saskatchewan, although it was great to hear all the progress that's being made. I remember speaking at the 2010 CAHR conference right here in Saskatoon. The number of new infections was already quite high at that time. I was speaking at a plenary session right after listening to a provincial politician who had just announced one-time funding of $250,000 for the provincial AIDS response. Even then, $250,000 was a ridiculously small amount of money, and I told him that during my talk. It was clear to me and everyone else in the audience that HIV among First Nations in Saskatchewan was not a provincial priority. Since that time, the HIV epidemic in Saskatchewan has marched on. The impact among First Nations communities is clearly disproportionate and unacceptable. These infographics from the Public Health Agency of Canada illustrate the extent of the problem, with rates far exceeding the national average, and 70% of the provincial HIV infections occurring among Indigenous peoples. It must be stated that this is not just a problem for Saskatchewan. There is not a province in Canada where First Nations people are not overrepresented in the HIV statistics. The health of Indigenous people across Canada is in crisis, and HIV is just part of this. This is one area where HIV researchers and the medical community have not been very effective. There has simply not been enough organized advocacy to draw attention to this problem or sufficient input into what to do. With some exceptions that we heard about earlier this evening, we have not been able to step out of our rigid approaches to HIV care, treatment, and prevention. Instead of being open to new ways of engagement that acknowledge the unique needs of Indigenous people, we have only managed to make minor accommodation in the way we approach HIV. We have clung to paternalistic medical models that have not been working. We have been very reluctant to go beyond standard evidence-based programs and have not listened to the affected communities. There are many examples of this. Ironically, for the most part, we tend to blame the communities themselves for not listening to our bad advice. It is time to provide the necessary resources and follow the lead of these Indigenous communities. Closely associated with the HIV epidemic among Indigenous peoples is the national tragedy of murdered and missing women. While this has occurred across Canada, a lot of the attention has been focused on British Columbia. I was actually working in the downtown east side of Vancouver during the years when over 50 women were murdered. How did this ever happen? And after the conviction of Robert Pickton, why haven't we taken steps to protect women and change the way we approach sex work? The perils of women working in the sex trade have not substantially changed since the Pickton trial. That was in 2007, 12 years ago. This is not to say that Canadians are not aware of the crisis. There have been a groundswell of activism and attention given to the issue. But to this point, there has been little movement on the laws and policies that are required to provide safety and improve lives, especially for young Aboriginal women. The structures, policies, and laws that society has put in place directly perpetuate the problem and must be changed. The activism necessary to force these changes is far from over. Yeah, give me a break. Thank you. HIV transmission among people who use drugs has been a tragic and largely avoidable crisis in Canada. It was known very early in the HIV epidemic that the infection was spreading easily and quickly among people injecting drugs. During the mid-1990s, it was estimated that 1 in 3 active drug users in Vancouver were HIV positive. If not for unsanctioned needle and syringe distribution, this would have been even higher. People who injected drugs in other Canadian cities also experienced high HIV rates, but the density of drug users living in the downtown east side and the intensity of the drug use set up this community for an unprecedented HIV outbreak. As would be expected, not only were HIV rates exceptionally high, so were hepatitis C rates, overdoses, injection-related infections, and overwhelming community-based suffering and despair. This is an iconic picture of Dean Wilson sitting in front of crosses in Oppenheimer Park during the last overdose crisis in 1996. Over the years, the downtown east side has hosted a range of natural and scientific experiments. It has been the site of innovative supported housing projects, low-barrier medical clinics, needle and syringe distribution projects, the emergence of drug user advocacy groups like VANDU, antiretroviral support programs, street nurse programs, the Naomi heroin trial, the Salome hydromorphone trial, and many other leading-edge projects. But perhaps the most famous of all is Insight, North America's first supervised injection site. Opening in 2003 and saved from our very own federal government by the Supreme Court in 2011, Insight has attracted international attention and has paved the way for new sites across Canada. But it is pretty safe to say that all of these innovations that I've talked about, including Insight, were led directly by the community and supported by NGOs. In the case of the downtown east side, a lot of the credit should go to VANDU, the Vancouver Area Network of Drug Users. And the Portland Hotel Society. Again, it should be noted that the evidence came later. The opening of Insight only came after the establishment of unsanctioned sites and the determination of community members to break existing laws. While efforts to enhance HIV prevention, testing, and access to care and treatment must certainly continue and be improved for people who use drugs, the overdose crisis has now become the dominant issue. Over 10,000 people have died from an unintentional drug overdose in the past 3 years in Canada. There have been 4,000 of these deaths in British Columbia alone. All the available harm reduction programs have been no match for a street drug supply that has become unpredictable, unstable, and toxic. The only reasonable response is to offer people a safer drug supply. It is always made sense to offer people a legal, regulated option to receive drugs. Expecting people to buy drugs from an illegal, unregulated market that is run by organized criminal gangs never made much sense. However, the situation has changed dramatically in the past few years with the disappearance of heroin and the increasing restrictions on opioid prescriptions. Prohibition created an extremely dangerous situation for people who are purchasing these drugs from the street. My own thoughts on a legal, regulated supply of opiates have gone from, this is probably a good idea, to this is absolutely necessary, to this is a moral imperative. Admittedly, not everyone has joined me on this journey, but I think that the idea is generally gaining momentum. 2 years ago, no one was really talking about a safe supply of opioids. Now a lot of people are, including governments. I was speaking at a community forum on safer drug supply in Ottawa just last week. As a member on a panel, I was asked, who is deciding that drug users should die? I was initially stumped. I hadn't really thought about the overdose crisis in those terms. What if 10,000 Canadians accidentally died of something else? Wouldn't there be some sort of inquiry? Wouldn't this dominate the news and be at the top of the political agenda? And wouldn't we be trying new things? Who is deciding that drug users should die? It is actually not that different of a question than we asked around who should die in Africa. We had the drugs that could save people's lives, but it was just a little too much trouble to get them out. Where's the logic? For over 3 years, we have known that every exposure to street drugs carries a risk of overdose and death. We actually have drugs that people would use instead of street drugs. But somehow we have decided that it is too much trouble, and there may be unintended consequences. To me, it is hard to imagine any unintended consequences that could make the overdose crisis worse than it is now. A scale-up of the safer supply of opiates to levels that would be needed to reduce overdose deaths across the country will require low-barrier programs that do not require observation of every dose. It will also be necessary to offer inexpensive opioid pills that can be crushed and injected. In Vancouver, we are working on a project that would dispense hydromorphone pills through a biometric dispensing machine. This is fully programmable and very secure. It can track the dispensing of each dose in real time. It will give people some autonomy over when and how they acquire their drugs and can still provide rapid access to services when requested. Not only would a safe supply essentially eliminate the risk of overdose, it would provide much-needed relief from the constant pressure to acquire drugs and reduce the criminal activities that are driven by the illegal drug market. Many of the challenges that we face in HIV can be captured by the concept of structural violence. Well, the term was introduced by Johann Gultang in 1969. A very useful definition was provided by Paul Farmer. Structural violence is one way of describing social arrangements that put individual populations in harm's way. The arrangements are structural because they are embedded in the political and economic organizations of our social world. They are violent because they cause injury to people. My own career in public health has really been focused on identifying factors that are associated with HIV infection and other serious illnesses. These factors are commonly called social determinants of health. There are books and entire journals about social determinants of health. Much of the epidemiology presented at this meeting will be about social determinants of health. We will discuss childhood trauma, residential schools, sexual violence, youth in care, mental illness, criminalization, incarceration, homelessness, stigma, and a whole range of things that are associated with the risk of HIV infection. These, of course, are all critically important, and we need to talk about them. However, in recent years, I have found the term social determinants of health does not really capture what is happening. It is just too passive. It is as if these social determinants of health are random events or just things that sort of happen to the unfortunate. It seems difficult to turn these associations into action. Structural violence is much more actionable. It recognizes that these structures are constructed by society and therefore could be changed. They are not some random event. Whether it was the residential school system, the welfare system, or drug prohibition, these environments have been created by us. Our job really should be to identify this structural violence and advocate for change. These are pictures of structural violence, environments that we have made and are perpetuated through our laws and policies. The plight of drug users living in tents, food insecure, surrounded by violence, in and out of prison for drug use, and now the constant threat of overdose, are all structural violence. They are not simply determinants of health. If you actually ask people who are at risk of overdose and HIV and other bad outcomes what they really want, it is not more medical care or harm reduction. It is knocking down the structural violence that is their world. This is a poster from last year's Day of Action on the overdose crisis. notice that there is nothing about more addiction treatment, more harm reduction, or more recovery homes. People want an end to oppression, criminalization, and poverty. And not until we fix some of these structural barriers can we provide the necessary care and treatment. I will finish up with a few thoughts around advocacy. I've tried to illustrate through these historical examples that change and progress was largely driven by advocacy and activism, that many of the innovations and progress that we have made in HIV came through doing the right thing. The support of research, while important, came later. In fact, research findings on their own may not move the dial that much. In areas where minority rights are involved and where ideology and political expediency rule the day. This is where advocacy is critical. So what does advocacy look like? Who should be doing the heavy lifting, and what are the steps of engagement? Well, I've created a ladder so that you can decide where you currently stand. All the steps are important, and you can technically move up and down as required. The progression from researcher, medical expert, to translational research, to advocate, to activist, and finally to shit disturber. Like with all ladders, the higher you go, the riskier it becomes. But like all climbs, the higher you go, the greater the rewards. You might ask, does climbing this ladder impact on our credibility as scientists? It might. If you go too high, you may no longer be viewed as an impartial and dispassionate researcher. You may never actually be able to back down. But as you learn more, it becomes harder to remain an impartial and dispassionate researcher. I have had some personal experience with this as I have been trying to find my own footing. This is a picture of some direct action against the federal government's cuts to refugee health care that would have had an impact on access to HIV treatment. Direct physician activism won out in this case, and the damaging policies were reversed. During these actions, I even had Jason Kenney, who was the immigration minister at the time, refer to me as an anarchist. You'll notice that the highest rung on my ladder was shit disturber. Presumably, anarchist would require a higher ladder. Donning a black hoodie at a protest is probably getting nearer the top of the ladder. This may not be necessary for everyone, but at the very least, communities who are fighting for their rights, and in many cases their lives, deserve our support. I am always surprised that so few people from the medical and research community participate in protests. They're great fun, and they're really important. At this stage of the HIV epidemic, 35 years and counting, we should realize our efforts will be limited without real change to the social drivers of the epidemic. We need to recognize that structural violence, the things we do to people, and the environments we create need to change. So, does HIV cause AIDS? I'll let you decide. Thank you.
Thank you. That was a really wonderful lecture to bring us full circle and remember where we started and how much work we still need to do. Thank you so much. Well, we're almost done, so you can enjoy yourselves this evening. Just a few more things that we need to tell you that I think everyone knows. There's a welcome reception. to attend that's right outside these doors. So just before we go there, we want to remind everyone for the conference that you can download an app, and you can find the instructions on the on-site program book, and I think they're going to put them up on the screen here. And so if you need any assistance, the volunteers are wearing blue shirts, so look for any of those and ask any questions that you need, and they'd be happy to help. So, and if you're looking at the posters now and you realize the speakers aren't there, they are supposed to be there during the afternoon coffee break. So if you're looking for the person to talk to, you can find them there at that time. So thank you all for listening to all the talks, and Alexandra and I. And we now would ask that you can proceed outside and enjoy your evening. Thank you very much. Thank you.